Good morning, everyone. We're here again. We're like, wait, who starts? This is how professional we started this morning. All these stressors off.
Yeah.
So, Alex, why don't you get us started? What are we talking about today?
Yes, today we're going to be talking about the difference between when we're supervising interns or supervising individuals who are unlicensed, the difference between clinical versus administrative, and what we're allowing them to sign off and not sign off on, and what's so important about this as well. So the reason we want to bring this up is there's a lot of people who ask, well, why was I allowed to do this as an intern and I can't now here at this job? And I think there needs to be clarification and a clear understanding why we allow certain people to do administrative stuff, enter it in the client's chart or electronic health record without signing it off, and why we are extremely cautious and careful with clinical stuff. So we're going to be talking about the difference between those both. So who wants to get started with either clinical or administrative?
So, Jen, do you want to share what's clinical and what's administrative?
Yeah, sure. So clinical is, clinical should be basically everything that's being tied back to a treatment plan. So clinical is the part that we actually went to school for, the counseling part of it. What are we doing as far as interventions? Why are we doing that? What's the client's progress? What are things we're noticing? Those are the kind of things that we're wanting to chart in clinical, right?
Mm-hmm. So specifically, let's pause for everyone who's out there.
Yeah.
So we're talking about the intake, we're talking about the treatment plan, we're talking about the notes.
Mm-hmm. Correct.
Go ahead. So administrative will be what?
I called the client called to reschedule, looking for resources outside of the community, anything that has to do with case management, anything that has to do with resources outside of clinical.
Mm-hmm. So what Alex is talking about is that it's very common when we're coming from school to work and get this practice under the supervision of someone else. It's not that different than when you were in school and you were the supervision under instructor and the site host. However, our brains are really good about comparing it, and usually is when we're in discontent. So why do I have to do this, but I was allowed to do that? It seems like we're dealing with teenagers again. No, you're not a teenager, and this is completely normal. That's a brain function of trying to make sense of what is the next phase. What are you asking me to do? Specifically, if we were not completely clear, or like in school, we did not pay attention that day on what is it that a supervisor is responsible, liable for you. And because of that, what is it that we want to make sure is paying a lot of detail on?
And the other thing too is we want to make sure, as you're entering the field and you're fairly green, we want to make sure that the diagnosis, the findings, the biopsychosocial findings that you find with the client is accurate. In other words, sometimes we have, we can have a client who is anxious or is depressed, and come to find out the totality of the events is PTSD, and you're just focusing on major depressive disorder or generalized anxiety disorder. And when you look at the totality of the events, because you don't have experience, let's say, or you've never been with someone who has complex PTSD, you really don't know. So you're honing in on what you do know. There's some clinical pieces there that you can still take into consideration once you do that peer consultation, or you do supervision with us, where you can get the right diagnosis, so that can cover the cost of the services that we're going to be able to offer within the agency or within the practice.
So if you have followed us, you have seen videos where we discuss how it's needed to give certain diagnosis, proper diagnosis, so the client can receive access. Mm-hmm. And being able to take our time to zoom out, and based on that intake, being able to see what are other possibilities, what are we ruling in, what are we ruling out. And that's what Alex is talking about right now. And at the beginning, everything is overwhelming. Can we say that?
Yes.
Yeah.
And it's not that this is like green versus season, which I hate that word, because you're telling me that I'm old. That's the bottom line.
That's what I'm hearing. Yeah.
That's what I'm hearing.
Yeah.
It's not, it's just that we have gone through that, and we're able to pause and look at specific things to see, is this applicable here? Mm-hmm. What would you add, Jen?
I mean, I guess the thing that came up with me is and it's like my least favorite phrase right now, looking at things through a trauma-informed lens. If we are looking at trauma-informed care, which we all are.
Yeah.
Spoiler alert, we all are, because that's what we were trying to. That's my least favorite phrase. But I mean, the whole point of that is, like Liliana said, to zoom back and see, okay, yes, your symptoms are indicative of anxiety. You have depressive symptoms, you have anxiety symptoms, but what could those, what really might be going on in the background, like what might be causing those? And I think that that's, also something that just kind of comes with time and with supervision and kind of learning more about it, is to make a, kind of delineate between what are symptoms and what's a diagnosis too.
Correct.
Beautiful.
Yes, you can have a diagnosis of anxiety, that's okay. But you also might have anxiety symptoms. You also might have some depressive symptoms. And we're going to look at those as part of the bigger picture, right?
Yeah. Correct.
Yeah.
And I actually want to piggyback on that, because that's where my substance abuse comes in. It's like, yes, they are using alcohol. Yes, they are using, cocaine. They're using depressants, a stimulant, as a coping mechanism to the PTSD, to the anxiety. So you start realizing when there's co-occurring disorders, we want to make sure that we're addressing all symptomology and be able to get, the medical necessity covered with the diagnosis for the interventions that we want to implement and put in place for the client. Not only whether it be individual level interventions, group level interventions, or whatever other treatment modality we want to put in place. We want to make sure we document correctly with the diagnosis, medical necessity, circles back to treatment plan, and everybody gets reimbursed. So.
And the quick piece too is that other reason why we want to help you is because depending on the setting, you may have limited sessions with the clients.
Yeah.
So now we have to go and choose in a way what is it that needs immediate assistance while we figure out what else can we do for this client, right? So if it's a specific system or setting, now we not only have to pay attention to the symptomology, the diagnosis, but also what can we do in 12 sessions? Yeah. That includes intake, termination, and like, what can we do here? So it's a sense of urgency that we understand, and we want to slow it down in order to help you here.
Correct.
Yep. And that part's hard because it's a different model. What you said, Liliana, when you have limited sessions, we were also trained to, again, like, we are supposed to slow down. We are supposed to look at everything and give space. And, but if we have a limited amount of time, there may be things that clinically we pick up on. We're like, ooh, that's a different topic. And we have to kind of compartmentalize that because we are only allotted a certain amount of time to focus on this. And so it's hard to redirect as a therapist, because you want to go in this direction and you want to go back and let's and cover all your childhood trauma and do all of that, but we can't. We got to focus on this one thing right here. So that also just takes time, and really honing in on the importance of why you want to have some kind of consultation for somebody to help you kind of guide you back to what you need to do clinically and administratively, like I don't know. How do you have to change it? How you want to do it, maybe, to make it fit? Which isn't always like fun. It's not great, but we do it. It's still more helpful than anything else.
So what is one takeaway that we want to share from this topic of clinical versus administrative supervision, and then why we suggest doing what we do and the signatures that go along with it? So one takeaway that we want to share with anyone who's viewing this video today.
I think, if anything, do your due diligence and make sure you have documented the accurate documentation for medical necessity and clinical justification of the services you want to provide.
Beautiful.
And then have that, but also refer back to it and make sure that you're following your own treatment plan so that you are reflecting back and you aren't getting off track and you are kind of staying in the lane of what you're wanting to focus on right there.
Beautiful. And go to your mentor, go to your, to your supervisor, not because they know more than you do, is that they have more experience And we want to make sure that what you're putting on all that documentation is what needs to be there, not putting all the life story word by word, and also not putting so little that they do not get services. So this is where we all come in, and we just want to share what we have learned along the way.
Mhm.
Yeah.
Right.
Yep. So until next time, hope this was helpful. And if you have any ideas in regards to supervision, send us our way.
Yes.
We're here to help with whatever we can. All these seasoned supervisors are here to share their experience.
Yes.
Okay. Bye.
Bye.
Bye.